privileged to welcome Professor Nihal Thomas, Senior Professor of Endocrinology. And thank you very much, sir, for having come today. And we look forward to your useful session. Thank you very much, sir.
Thank you so much for the introduction. And since we have a sellout audience, maybe all you guys can come in the front row. At least I think 3 of you have done your MBBS here. Oh, you also have. No, don't say outside. You did it in a different world. How about you? Ludiana, come forward. Come. All right. So this is, as I was just telling boss over here, that this is a fairly large topic, and it's a huge overlap between general medicine, endocrinology, genetics, surgery, biochemistry, you name it. And I think the only way you can master this area is by seeing as many patients as you can, like in any other area of medicine. But I'll try and give a little snapshot, and it's best that you ask me questions as far as these things are concerned. All right. So just to wake you up a little bit and give you a philosophical bend of mind, fever, weight loss, and other forces may mean adrenal histoplasmosis. You could Anglo from Rome. You may be having Cushing syndrome. With a heart that's weak and a gut that's void, it may well mean it's adrenal amyloid. With darkening skin, a craving for salt, aldocortisol, their production may halt. With a racing heart and raging pressure, it's Pheochromocytoma. It's not leisure. Yours truly. I hope you all wake up now. All right. And since it's a sellout audience, maybe you guys can all come in the front. Thank you. So there's a very nice book written by these two British physicians. As you can see, the names are totally British. Endocrine, Hypertension, and it's a very nice book actually. You can buy it for the Department of Medicine. It's probably worth getting it, and you can spend the rest of the year reading it and focus on this rather than all the other stuff that you're doing in your post-graduation. Right. So maybe we can have some quick answers over here. The commonest causes for secondary hypertension from among the following in an adult in order of merit. Okay, you. Give me the answer, quick. What's on top of the list? Anybody? Don't think. Be instinctive, right? Hyperaldosteronism. You've been in endocrinology recently, so throw you out of the window. Hyperaldosteronism is second. Who's next? What is the second one on this list? Of all these in an adult patient. Endogenous Cushing syndrome, right? Third. Littles is like, if you ever see it in an adult, I'd be extremely happy to see it. So that's really at the bottom of the list. And I'd probably put Pheochromocytoma in an adult. Congenital coarctation maybe a little lower than this. So Pheo is actually way back on the list, but the paradigms for management are boundless. It's a huge area which you need to handle. And therefore, but remember that primary hyperaldosteronism is the commonest of the lot. So also, once again, as endocrinologist, I need to constantly remind my postgraduates that renal disease is the commonest cause of secondary hypertension, and endocrine is way behind renal disease when it comes to secondary hypertension. So please rule out every cause of renal disease before you start investigating any patient for endocrine hypertension. Really, really. Right. Okay. Thank you. So always rule out the creatinine and the urine sediment, the very innocuous, humble urine sediment is so often missed in patients and very often missed. Even nephrotic range proteinuria with a well-compensated albumin has been missed. Kindly rule out those as conditions. So coming back to the question, and this is in order of merit, the commonest cause by far is primary hyperaldosteronism. which is about 5 to 6% of all adult hypertension that you're seeing in a tertiary care center. And it is worth ruling it out. It doesn't necessarily mean that you're dealing with a tumor over there. It could be what we call idiopathic hyperaldosteronism. And very briefly allude to that as well in addition. Okay, so when you look at an imaging on the adrenal gland, which is a CT scan, so you have organized entertainment as well, music in the background, and that's wonderful. So the relative size of a right adrenal gland in cumulative thickness. How do you identify an adrenal gland on a CT scan in terms of its size? Anybody? Quickly. It's one of the most challenging things. If you don't look at the adrenal, then you will have even difficulty finding it on the CT scan. That is how it is for most physicians. But you look at the crust of the diaphragm and you compare it to the size of the crust of the diaphragm. And if it's thicker than the crust of the diaphragm, we generally say that this is adrenal enlargement. All right. So the 4 or 5 things that you need to look at when you're looking at. And there is an objective size to the adrenal gland as well. Anyone, any guesses as to cumulative thickness? What is the cumulative thickness here? Any wild guesses? Inspired thinking? A lot of intelligent people sitting at the back. They can probably give answers as well, right? Sorry, consultants are not supposed to answer, right? 5 millimeters. Okay, good. Not bad. Just multiply by 3 and you get the correct answer. 15 millimeters. Okay, this is published by Ritu and other people on this slide. And it's fairly recent. And it's the only Indian database telling you about. There may be a bias in the study because this is done in CT scans for guys who had CTs organized for various reasons in the institution. It's not doing a CT in a normal person. And even chronic stress can increase adrenal glands. So those of you in your training in the next 3 years, do a CT and you'll find your adrenal glands might be more than 15 millimeters in size, right? Department of Medicine will fund the CT scans for all of you. Thank you. So the correct size is 15 millimeters over here. And so when you're looking for an adrenal anomaly, few things that you look at. One is you compare it on both sides. For example, in conditions like Cushing syndrome, because the cortisol is being produced, that is Cushing's syndrome due to an adrenal adenoma, not pituitary. Pituitary will be bilateral hyperplasia. One side will be enlarged and the opposite will be atrophic. Now that should not happen under normal circumstances with hyperaldosteronism or most of the other causes for a tumor. So if it's producing cortisol, the opposite side will atrophy. So that's one basic premise over there. So you do a plain CT scan and then do your arterial phase. Tumors like which are not that vascular, like Conn syndrome extra, lipoid rich, have low Hounsfield density. Classically speaking, there are ones which may have lipid rich as well, lipid poor as well, but they are classically lipid rich. The Hounsfield density is usually less than 10. Whereas in pheochromocytomas, when you do a CT, the tumors are, of course, much larger. Size is important, more than 2 centimeters by and large. And they are vascular. So you give arterial contrast and they light up on a CT scan. In fact, in the olden days, people used to do arteriograms. Till 1989, there wasn't a CT scan in CMC. And people used to do arteriograms for, and that's how they used to identify that. Look at the blush, arterial blush on top of the kidney. You can't actually see the tumor outline, but you see the blush of the blood vessels actually coming out there. So we're just going to go through a few histories. 54-year-old female, history of intermittent headache, sweating and palpitations for the last 4 years, had been on treatment for hypertension and diabetes for the last 13 years. Physical examination normal, hemogram and liver function tests normal, right? What are the diagnostic possibilities in this patient? Anyone? Migraine, hypoglycemia, pheochromocytoma, diabetic autonomic dysfunction, menopausal symptoms. All of you have had endocrine postings? If you haven't, please answer the question. Right? Pheochromocytoma. So when you have these symptoms, I'm quite certain that your professors have all taught you that the first thing you should think about is the Pheochromocytoma and a guy who walks into the OPD. Correct? It's as common as the hairs on my head, which is progressively declining in the last few years, but even then, it is common, right? Am I right? No, but let's look at the symptoms. Diabetes, right? All right. He's on oral anti-diabetic agents. She is an old. She's 54 years old. So if you look carefully over here, it could very well be migraine. Please ask them if it's been happening for the last 15 years. Okay. It could be hypoglycemia. Could be a pheochromocytoma, certainly. It could be autonomic dysfunction. You can have these adrenergic symptoms or paradoxical symptoms, and you can even have rise in blood pressure in an autonomic dysfunction sometimes. And menopausal symptoms, it can be pretty nasty. Okay. Now, in this audience, hopefully 70% of you will not experience menopausal symptoms. Yeah. Can males have hot flushes? What do you think? Right? Are you having one right now? Males can have hot flushes. So the testosterone levels are down and the FSH levels are up. Males can have hot flushes. It's known. Now, that's not something which is invariably going to happen to 90% of you, hopefully, but that can also occur. So, rise in any of these symptoms, and remember, fear is probably the rarest of all these things. All right? The rarest. So, this patient could very well be having anything else but a pheochromocytoma. So, please think about these conditions because this is the differential diagnosis for pheochromocytoma. All right? Otherwise, all your patients will be having urinary metanephrines and a CT of the abdomen without fail, and that's going to be a major financial disaster for you and for the patient. Right. So these are the things, and please think about all of them as potential, and things like, okay, diencephalic seizures, carcinoid, really lower down, probably even rarer than pheochromocytomas if you want to put in mastocytosis all there. And even these medications, these drugs of abuse could very well be the case. In a younger person, please think about that as a potential thing because these things are pretty much becoming more and more and more common. Be extremely aware of this. Okay, all of the above. So the recurrent abdominal pain and sweating persisted. Solitary recording of blood pressure greater than 180 by 130 was recorded. And this is the CT of the abdomen. So there are three views over here, and they give you three very essential pictures and tell you what's going on there. This is a describe what you're seeing. Okay, I don't think we have the time to kind of become too narrative over here, but that's a lesion which is easily more than 8 centimeters in size, and it is apparently above the level of the kidney over there. I can't see the normal adrenal gland in this picture, but it's always nice to see the normal adrenal separate from the tumor, so you know that it is whether it is attached to the adrenal or coming from the adrenal, or could even be a paraganglioma in this site if I'm thinking of a catecholaminergic lesion. And then that's the arterial phase, and you can see it's lighting up over there. And there are areas of necrosis over there. Tumor becomes bigger, it outgrows its capacity, it starts developing areas of necrosis. It could bleed, it could be a bleed, it could be necrosis as well, and cystic appearance occur as they become bigger and bigger as well, in addition. Right, look all over the abdomen because I'd like to see if there are multiple paragangliomas, or the opposite adrenal may have a much smaller lesion as well, so they could be bilateral in addition. This is the oldest publication from our institution way back, and my teacher, and probably my teachers, I should say, endocrine surgeon and endocrine physician, who were there, 35 patients, and all these, most of these patients would have had maybe CTs, but it was a urine vanillin malic acid we were using in those days. Remember the end product of your catecholamine aspects. Some angiograms and some MIBG scans, because this is the first place in India which was doing MIBG scans in the year 1993 over here as well. So what do these tumors largely produce? Epinephrine, norepinephrine, dopamine, both epinephrine and norepinephrine, both epinephrine and dopamine. What's the correct answer? Any guesses? Why do you say that? Any reason? Is there a phylogenetic reason for it being norepinephrine? So the answer perhaps is not that straightforward. And I won't fault you that you didn't give the answer or not. But if you look at the so-called production, physiological, biochemical production, it's an evolutionary process. Tyrosine, dopamine, norepinephrine, epinephrine. So when God created the autonomic nervous system and the adrenal glands, it was a process over there. So the adrenal medulla normally produces epinephrine. The norepinephrine is from the medulla and the autonomic nervous system. And dopamine is from the medulla, autonomic nervous system, and the central nervous system. The three areas. So it is quite logical, therefore, to think that if it's a pure adrenal lesion, it will produce only epinephrine. Or if it is a medulla and if the paraganglioma coming from the sympathetic chain, then it is likely to be norepinephrine. Yeah, maybe to some extent as well. All right. And so remember that each of these enzymes over there have a very specific role in the conversion processes as well. Okay. So let's come to the answer. Most pheochromocytomas produce predominantly norepinephrine, mainly those in extraadrenal location. Many produce both norepinephrine and epinephrine, typically adrenal tumors. They produce both. Because to get epinephrine, you look at the cycle once again, norepinephrine and then epinephrine. So that's how it is. All right. Why is it called epinephrine? Why is it called epinephrine? Because of the methylation, can you see at the end over there? That makes it epinephrine. So that is the last product. So to get epinephrine, you need so therefore, logically speaking, it's a phylogenetic process. All right. Some produce predominantly epinephrine, only adrenal tumors in patients with MEN2, multiple endocrine neoplasia type 2, and neurofibromatosis type 1 produce, which is of course extremely rare. Now these are actually, you should start thinking of these things as well, but this, if you see this, I've probably seen maybe 3 in 30 years, and so that's rare. Dopamine producing tumors, particularly from these very aggressive genetic things, and this is not exotica, it is one of the important causes for pheochromocytoma. Okay. One quick look over here as to talking about the processes of a constitutive secretive pathway as well as a regulatory secretory pathway. So constitution is in the formation process and therefore subsequently is the secretory process. So you could have defects in either of these leading to problems. Right. Okay. There's something called silent pheochromocytomas. Is it rare? What's the percentage of silent pheochromocytomas? Any guesses? Just guess. Anybody? Okay. You have to guess because it makes a big difference. I got into medicine guessing that I might become a good doctor one day. That's it. So just guess. What is it? What percentage? Yes? 2%. Okay. That's not quite close, but just multiply by 10. The correct answer is 20%. Okay, 5 to 20%. Why? Because we're doing so many CTs for various other indications. Previously, catecholaminergic crisis, you do a CT scan. Now, a guy has a vague ache in some part of his back, and you do a CT scan, and you get a pheo. And it, of course, it could be the expanding capsule and all that stuff which is causing the pain, or it may be something totally unrelated. So it's being picked up, and they are silent. Is silence golden? And the answer is no. They should all be taken seriously, right? These are all nasties which at some point of time can explode. Might explode at the age of 75 or 80, it may never explode, but it could explode anytime. So you can get a catecholamine crisis at the age of 75 or 80. I'm not joking, I'm serious. All right, somebody comes with an SVT at the age of 65 or 70, who knows, it may be an underlying pheo in this guy. It could. Right. So, right. So this is, we switched over from catecholamines to, I'm sorry, from vanil mandelic acid to metanephrines in the year 2013, just after this got published. And that's what we're using. Someone will ask you in, do you have MCQs for your medicine exams these days? Exit? No, you don't. I thought it was there at some point of time. No, it's been removed. Okay. But anyway, if you write a short note, what is the gold standard for biochemical testing for catecholamine producing tumors? Anybody? Gold standard. Plasma metanephrines. Okay, we don't do it. We have the technology to do it. So over here, we use the high performance liquid chromatography. We need the LCMS to do it, and we do have the LCMS, but it will end up being 5 times more expensive. But the proof of the pudding is in the eating. And for me, the eating is the CT scan. Seeing is believing. The catecholamines are just markers which tell us here, there, and everywhere that we're going somewhere. There's one group of tumors, I'm just mentioning it because of, to understand the beauty of physiology of and biochemistry. Dramatic cardiovascular collapse after Aldosteronism. This is one tumor where you should be ideally not using alpha blockade. Now, we're not routinely checking dopamine. In fact, we've started checking it and we just stored up the samples, and basically we're not enough reaching the lab, and so finally they scuttled the idea. But we were actually doing it at one point of time. But just remember, there are certain types where it can actually be more common. In the STHB mutations, particularly the metastatic types, they can have it. So that's why we always start with a very small dose of we never know who might actually have a dopamine producing tumors, because they have the enzyme which converts to the next step of formation of norepinephrine is generally low, so they can have hypotension if you give one dose of alpha blockade. And dopamine does not work on the alpha receptors, right? It works on the D2 receptor. So you give alpha blockade on top of that, that's it. The existing alpha blockade, existing adrenergic drive is killed, and they can have a huge drop in blood pressure and can be deadly. So, and with betas, it's even worse. So we don't use alpha block. We're not supposed to use alpha block. Think about it. So the rule of 10% is now obsolete. It's no longer the 10% tumor. You can please go and tell your pathologist that 10% tumor. I mean, they won't tell you that either, because I think they also know now that it's not a 10% tumor, but they still teach it in medicine that you're 10% tumor. No, the chances are that you're only 10% of the time correct if you're calling it a 10% tumor. 90% you're wrong. So 15% extra adrenal, we should think about it more. 30% familial, and that is why genetics is so important, because predictive screening, the nature of the tumor, the ability to metastasize at some point of time, the kind of chemotherapy you give is going to be different. 10% malignant, adrenal Pheo 10% malignant, familial Pheo 5%, extra adrenal 36% malignant. And it may not be picked up very obviously on the histopath, because these are metabolically very active tumor. They have very kind of overexcited mitochondria sitting there. They are pleomorphic. They divide. So it's not, you can't figure out malignancy straight and simple from all that over there. 14% local recurrence, 5 to 10% in children as well. So we should be thinking about it. Now this is the work, and I would like to give due credit to my colleague Dr. Simon Rajaratnam, who passionately did a lot of adrenal work and pituitary work in his day, and Dr. Rekha Pai, who has done the pathology over here. What kind of genetic testing you think has been used over here for this? What are the kinds of genetic testing you know of? You attended a lecture in the morning, so you might know something. Right? When you do genetic testing, there are kinds of sequencing. What kind of sequencing was used here? Who? Which one? Who discovered the structure of the insulin molecule? Same guy. Sanger, right? Which year did Sanger die? 2014, right? Anyone from the 2014 batch over here? No one. Right. Okay. And you don't even know who he is. He died in 2014, Sanger sequencing. Nowadays, we're moving over to next generation sequencing. And massive parallel sequencing wherein you put all the genes together and do it. And we are doing that for a lot of our genetic testing from our own molecular lab. We are switching slowly to the Sanger, the next generation sequence, where you can line up all the genes at one shot. Very cost effective when you actually do it that way. So, okay. So why do we do genetic testing? And I'm just highlighting the fact that we need to be doing it in all patients who have paragangliomas, bilateral adrenal Pheos, unilateral Pheo with a family history, unilateral adrenal Pheo at a young age, less than 45. What is young? What is youth? Youth is less than? You need to know the answer. Less than 70, correct. You got it right. Other clinical findings suggestive of the associated syndromic disorders. So whatever you know, what looks like an MEN2 or an MEN2AB, von Hippel-Lindau syndrome as well. Now, what do you think is the commonest cause for familial pheochromocytoma? Any guesses? Backbenchers, not the consultants, the others. Okay. Commonest cause for pheochromocytoma, familial cause for pheochromocytoma. Huh? Anybody? Just because the Pope is sitting in the second row, it doesn't mean that you have to be quiet. Okay? Speak up when the Pope is around, and he will bless you in future. Tell me. Okay, right. Huh? Any guesses? I have to give you multiple choice questions, only then it works, right? Von Hippel-Lindau syndrome, or von Hippel-Lindau syndrome, whatever you call it, is the commonest cause for familial Pheos. And that is what my colleagues had shown very clearly, that this was with that technology at that time, that von Hippel-Lindau syndrome is the commonest cause, and not MEN2, which you might have known a lot better as well. So this condition is important because can you tell me the clinical features of von Hippel-Lindau syndrome? I'm not going to come on a slide over here, but clinical features, 1, 2, 3, 4. Sorry? Hemangioblastomas in the neuraxis and in the retina. You can get retinal hemangiomas, which can bleed suddenly, cause vitreous hemorrhage. Hemangioblastomas in the neuraxis. You can also, and bilateral adrenal pheochromocyte, usually adrenal, right? Pancreatic neuroendocrine tumors, which are very often just insulin insulinopathies, but occasionally, very rarely, can produce insulin. And one more tumor which can occur, which can be nasty, which is the nastiest abdominal tumor you can think of besides pancreatic carcinoma? Renal cell carcinoma, yeah. And to make life more easy for you guys, there are 3 types of von Hippel-Lindau syndrome, which I'm not going to be talking about over here. So remember, paroxysms in patients. Many patients with Pheo will come to you. They've been having these palpitations up and down, all that, and some would have put them on an antidepressant. And remember, all these things can be worsened by most antidepressants as well. Very important. So typical paroxysm over here, which you can describe, can be caused by a number of medications. And these are the things which we need to worry about particularly. Now, other than bananas and chocolates, I'm sure that most of you don't overindulge in most of the other things over here. But just remember that all these things can actually worsen symptoms as well, procedures as well. So if someone has been through pregnancy and comes with accelerated hypertension, the chance of being a Pheo pretest probability is very low. Or we have incidentally had people who have gone through pregnancy and had a Pheo diagnosed a year later, but that is unlikely with that degree of intra-abdominal pressure occurring over there. So, so here are the medications which can all worsen Pheo-like spells. That's a very impressive list over there, including high doses of glucocorticoids as well. High doses of glucocorticoids can frustrate. And I'm not going to tell you the reason for that. Please look it up. What part of the enzyme pathway can a big dose of dexamethasone actually have an effect that it causes catecholamine-like? And through the histamine relationship, morphine can worsen Pheo-like spells. Any of the semi-opioid agonists like tramadol can also worsen it as well in addition. So you've got a imposing list of stuff over here, and definitely some of them are not uncommon to use. Look at the tricyclics, and the SSRI is also in the list. 18-year-old lady with severe hypertension for 3 months, norepinephrine levels of 5,700, and you can see the CT scan over here showing one-sided cystic lesion, all right, and the opposite side, which I haven't gotten the cut as well. She also has this vascular lesion located in the where? What is that? Located in the, sorry, louder. Huh? Where is it located? What's that structure? Anybody? Do you guys communicate with telepathy? I'm not in your league, right? Huh? What's that structure? One long thingy over here. Pancreas, the love of your life or my life, maybe, right? Okay, the pancreas vascular lesion over there, which essentially is it's taking up, and so it means now what is your diagnosis? Tumors in the adrenals, tumor in the pancreas. Diagnosis: von Hippel-Lindau syndrome. That's your diagnosis there. This is called a MIBG isotope scan. It's the older study which we use, and we still use it a lot because it's cost effective. We also have the DOPA and the DOTA PET scans also, which are, and it's not necessary that those are always better. There are specific reasons where we do DOTA, DOPA, and MIBG, but this is cost effective over here. That's why you still do it, just to make sure that we don't miss other lesions sitting out there. That's why. Now, when you have bilateral pheochromocytomas, what will you do? One is 10 centimeters, the other one is 1 centimeter. What do you do? Remove both. And then what happens when you take off both? They're stuck to the adrenals, you take off both the adrenals. What do you do after that? No, nothing wrong with what you said. You said everything perfectly right. Some of you are looking very quizzical and think there's a twist in the tiger's tail. But you take them both off, and what happens? You give them steroids. You give them anabolic steroids to build their muscles up. Don't use that word in your life again. You give them glucocorticoids and mineralocorticoids, right? Prednisolone and fludrocortisone. Yeah, you do that. But there is a choice. And when we have the elegant surgeons endocrine surgeons that we have over here, they do wonderful things. So here, taken off the right pheo, and it's a big one. So the whole adrenal went, and the left pheo, they've taken off the tumor, but they've spared the adrenal gland. The cortex of the adrenal is spared. So you don't need to give prednisolone or fludrocortisone to this patient. All right, that's it. He's doing well without any supplementation. Otherwise, the other person, he goes to some remote area and he has episode of diarrhea, the BP crashes. He should have had his first dose of hydrocort at home and before he went to hospital. That doesn't get done. And so this, remember, is an option when they deal with bilateral pheos, and they can spare the cortex, at least from that side. Just reminding you, this is the Zellen-Bollen appearance which you get in patients with pheochromocytoma. Okay, don't they look like nests all over here, right? So that's what the histopathology showed over here. This is the phrenogram for the Sanger sequencing, which has been done, and it shows von Hippel-Lindau syndrome. She does not have retinal angiomas, but we need annual screening of the retina. We need a neuraxis MRI every 4 years. Even if she's perfectly normal here, we have to do it. We don't want her to come with a bleed into the spinal cord or cerebral hemorrhage because of a lesion which was not picked up over there. So they need to be done, and we do have patients who have multiple lesions which need repeated surgeries as well. And renal cell carcinoma, of course, depending on the type you're dealing with. So periodic MRI brain, spinal cord, CT, and followed up at least once in 3 years over here, annual optic fundoscopy as well. Right. Now there's something called clusters now for pheochromocytomas. You must have heard of clusters for type 2 diabetes, right? Yes? No? I don't know. All of the above? None of the above. Not heard of it? because someone in medicine was selling the clusters for type 2 diabetes, and I saw them actually labeling mild obesity induced diabetes, age related diabetes, severe insulin dependent. That's highly speculative. You can actually do it if you want to. But anyway, we're talking about Pheos, clusters for Pheos and paragangliomas, depending on the entomology, the basic biochemistry which is happening there and the genetic cause for it. Pseudohypoxia. So you think of hypoxia, when you have lack of blood, something will go to compensate, increase blood vessel formation, right? Increase substrate, and therefore a tumor will start growing. Kinase signaling and then Wnt signaling, which can occur. There are three categories, and we'll talk about them because they make a big difference to the long-term therapy. Some of you guys, when you listen to this lecture, will maybe inspired to go and take on endocrinology. But once I start talking about clusters, you'll all go and do medical oncology. So it doesn't matter where you go, I will lead you wherever you want to go. Right? So 50 to 60% of all patients with a metastatic PPGL may carry cluster 1 mutations, and therefore trying to figure out what you're dealing with. I'll come to these are basically Krebs cycle associated mutations. The STHA mutation, which is not as aggressive as the STHB as well, and certain other forms over here. Cluster 1B has von Hippel-Lindau syndrome, the one which I described to you over here. So here is basically the pathogenesis. You have the mutation over here subsequently, and then you have accumulation of this hypoxic ischemic factor, which leads to, which is associated with VEGF1 production, VEGF production, angiogenesis, TGF alpha with autocrine growth stimulation, and increased glucose transport. So that all is a stimulus for tumor formation. So your 31-year-old, next, go to the next patient, 31-year-old gentleman who had history of typical symptoms over there, had 2 swellings on either side of the neck, norepinephrine levels were high, and his urine metanephrine was normal. So this is a CT scan showing a very vascular lesion, as you can see over there. So sorry. All right. Enhancing in the arterial phase. And this is, I should have not labeled it. I would have asked you what this is. But these are bilateral carotid body tumors and an MIBG scan, which was done initially showing a lesion over here, the large lesion in this part. Now, I could do this MIBG scan at different points. I want to pick up multiple lesions, so I do it early. Or I go and take off whatever tumor is there. And if there's anything which I missed out, will become more avid after the surgery is over. And that's what we generally tend to do over here. Okay. So blood pressure control. How do you control blood pressure in pheochromocytomas? What do you do? The thing which you do not do for any other hypertension, you will do for patients with pheochromocytomas. What do? You give them lots of tanni, water. Lot of water and salt. Why do you give lots of water and salt? Because when you give alpha blockade and you do a surgery, we are in a vasoconstrictive state initially. So they suddenly vasodilate once the catecholamine drive is gone and their intravascular volume is depleted. So you need to replete it before surgery. Give them tons of fluid, 4 to 5 liters of fluid, 12 grams of salt for 10 days, and only then operate. Otherwise, if you operate without doing that, the blood pressure will just collapse like a bomb. So that's the preparation over there. And what medication do you give? Alpha blockade. The alpha blockade of choice is not prazosin. That's it. What choice does not mean what you get, right? Why are you grinning? Right. Okay. So you have a choice, but you may not get it. Phenoxybenzamine is the drug of choice, but it's very, very expensive, right? Therefore, people prefer to use prazosin in this setting over here. So operated normal MFPG, but then you need follow-up of all these patients. All these familial tumors need to be followed up. So here later a Doppler PET scan has been done and shows the lesions are taking up over there. What do we do for this patient? He's got to be operated, had a very invasive surgery, has a lot of fibrosis. The vascular surgeons aren't keen on going in again. This is a recurrence. What do you want to do? What are the options? If something is detected by an isotope, what do? You knock it with an isotope. So what will you give here with the Doppler PET scan? Lutetium. Okay, you give something called lutetium over here. That's what you can see over here. Now, this is another wonderful series published by my colleague and the vascular surgeons and Rekha Pai, which has covered this carotid body tumor story. Okay, this is very complicated cartoon, but it's then there on the net. Reference is, I think, Endocrine Reviews 2020. Shouldn't be accused of plagiarism, but it is Endocrine Reviews 2022. Very nice article on Pheochromocytoma, showing you how, in terms of a defect in the PET cycle actually occurs, mitochondrial dysfunction, which is there in these patients and which happens in these patients, and therefore the associated angiogenesis, which I talked about to you in VHL, mutations as well. Therapeutically, in case of recurrence or malignancy, the treatments are different. For example, in cluster 1, you can give octreotide, so metastatin analogs. You can give the lutetium basically has a relationship as well and gets bound in over here. So you can use other isotopes which are bound to octreotide as well. You can use therapeutic agents which are related to the basic pathology in these patients. A number of conditions which have been used, demyelinating agents which have been used over here. Temozolomide, which you probably all are familiar with, has been tried out in these patients as well. Specifically, I'm not going to go into the specifics, but just to show you how important it is to make a genetic, because these patients, even if they're metastatic, if you give them the appropriate treatment, can live for the next 25 to 30 years. And I'm telling you from experience, from when chemotherapy or isotope treatment was not that great, that we still have patients living with their tumors for 20 to 25 years. So there's a lot you can do for these patients. Neuroendocrine tumors are very different from other adenocarcinomas when they metastasize. So cluster 2, these patients have a better outcome than cluster 1. They're less complex if you pick them up early, and the red proto-oncogene mutation. So the red proto-oncogene is seen in which tumor? Anybody? MEN? Men, which men? You can say MEN1 and then multiply it by 2. The correct answer is MEN2, right? So it could be MEN2A or MEN2B, the red proto-oncogene. It's a proto-oncogene. It's not a tumor suppressor gene. So therefore, this is the commonest of the lot. The others, many of the sporadic tumors now are being picked up, and there are probably some of these in addition as well over here. So they all have very specific functions, and they may, in fact, help in determining the long-term treatment in these patients. But I won't go into the details. Read that lovely article, Endocrine Reviews 2022. 44-year-old gentleman presented with a history of severe hypertension and recent onset diabetes. Metanephrines, normetanephrines, normal, and but his serum calcium was elevated over here in this patient, and the parathyroid hormone was 131. Male patient with, what's your diagnosis here? Sorry? Primary hyperparathyroid, that's all you can say at the moment. But because of his hypertension being severe, he needed more than 3 medications, and therefore the workup for that also continued. Now, hyperparathyroidism can be also associated with hypertension as well, but we won't presume that, because that is an association which sometimes happens and not always. So the CT scan showed an adrenal mass in the workup over here, even though the catecholamines are negative. Remember what I told you? A good 20% may not have catecholamine elevation at all. So we went ahead with the CT. Stepwise, I'm not going to be trigger happy about ordering the CT. I would do it stepwise over here. And the MIBG scan shows bilateral lesions. Now the liver also takes up MIBG, a normal liver. But to be discreet, there is a right-sided tumor and a left-sided tumor, as you can see over there. Okay. All right. So pheochromocytoma should be suspected even with measurements of fractionated metanephrines and catecholamines are normal. And you can have something called pre-biochemical disease. 20% of Pheos can have a pre-biochemical presentation. That's a parathyroid adenoma. He's had adrenalectomy. He needed bilateral adrenalectomy. They couldn't do a cortical sparing over here. And thyroid also appeared bulky. So, I mean, I think this was a while ago, but this is the early 2000s. We would have straight away thought of MEN2 and gone ahead and done it. You know, suspected medullary thyroid cancer in this patient. Calcitonin levels would have been high. There's some problems here because calcitonin can be high when you have hypercalcemia. You know, it's a counter-regulatory hormone as well. So falsely elevated over there, but you would have expected much higher levels over there. And so this is MEN2A. Difference between MEN2A and B? One difference? Two differences? Anything? MEN2A, 2B, you don't have parathyroid disease. MEN2B, you can have mucosal neurinomas, right? And you may have Marfanoid features. That's what you might also have. So this is our publication in Clinical Endocrinology, once again spearheaded by my colleague, Dr. Simon, on looking at the red proto-oncogene. And these are characteristics because it's important, it's useful because there are certain forms of intronic variants which may be associated with more aggressive disease in these patients. So it is very important to do the genetic screening. If you have a mother who has the disease and had the surgery at 40 and she has a 2-year-old baby, what is the chance that this baby might be having the problem? Chance. 25%, 50%. It's a male baby. You have to ask me only one question. What is the one question you need to ask me? What is the inheritance pattern? What is the inheritance pattern of MEN? Autosomal dominant. So what's the chance of the baby having it? 50%, irrespective of the gender. So before the age of 5, we should do a genetic testing, maybe an earlier. Once it's negative, you can rest assured, no chance of anything happening. If it's positive, we should do a prophylactic thyroidectomy even as early as 5 years of age. And we've ended up doing prophylactic thyroidectomies, adrenalectomies also in some of these patients as well. So predictive screening is so important. It's not a sporadic, you have to follow these steps. It makes a big difference to quality of life in these patients. So here is cluster 2. Once again, showing you here, these tumors are responsive to the tyrosine kinase inhibitors, and very rightly so, because of the basic pathogenesis, the biochemistry. Over here, don't have time to go through this again, but the TK inhibitors, if you have patients who have metastasis, older patients who are refractory to treatment after surgery, we use TK inhibitors in these patients as well. Once again, temozolomide has been used in some of these patients as well. Okay. So depending on the mutation, you can even classify the disease and follow them up on a long-term basis. Cluster 2 tumors are almost exclusively located adrenally, whereas cluster 1s can very often, I've already told you about that, can be extraadrenal. So this is the algorithm which we follow. Generally, a CT is more than enough once you prove your diagnosis. We do isotope scanning as well, and adequate hydration with salt and water, alpha blockade for 10 to 12 days. Give the beta block only once you're adequately alpha blocked. Otherwise, you'll have a paradoxical crisis. You'll have a crisis. You can cause a fear crisis by adding the beta blocker too early as well. So phenoxybenzamine first, prazosin subsequently is the drug we actually use for most patients. So we're not using phenoxybenzamine by and large, and we find this actually pretty good. The people who are most concerned at the time of surgery are the anesthetists. So the thing is, you can have fluctuations in blood pressures, which could be a major issue in these patients, and therefore alpha blockade is critical. Despite all that, some of them have issues with their blood pressure. Now, generally, people use these gases. We are not in the era of ether and nitrous oxide anymore, and therefore all these provoke much less catecholamine excess. Anyone who's going back to a mission hospital over here? I mean, I don't think you're going to be operating on a Pheo in the middle of nowhere. Hopefully, well, if the patient can't come here, I wouldn't mind you doing it, but you need the tertiary care backup generally for these kind of tumors. Right. Here's some of the wonderful work that our endocrine surgeons do. Absolutely fantastic team which we have. The kind of backup, the anesthesia, everything. It's really, really good. Yeah. Okay, what's your diagnosis? Oh, I think I've put the diagnosis at the bottom. Right. So, lichen amyloidosis is the skin lesion. And in addition to that, you can see the thyroid, which is enlarged over here. And you can see the adrenal tumor. This is MEN2B, cutaneous lesions that you can see in these patients. Right. 25-year-old lady comes at the age of 15 years with hemiparesis, intracranial bleed, got married, conceived, uneven pregnancy. Baby was born with an LSCS, started complaining of headaches, found to have high blood pressure, profuse sweating. Okay. 5 years back, I was in Bangladesh, in Dhaka, for a meeting. I was on the 5th floor of this building. And then, you know, just preparing for my talk. And when you prepare for talks, you generally drink a lot of water. And so I wanted to go to the toilet, went to the toilet. Suddenly I felt like my head was swaying from side to side. And my first diagnosis, like any good endocrinologist, was I have a bladder pheochromocytoma. It just continued like that, but I didn't fall down. So I just came out and looked out of the window. Everyone was running out of the buildings at that point of time. So it was an earthquake happening in Nepal, and the shocks were being felt in Dhaka at that point of time. Right. So think of common things first, right? Think of earthquakes before pheochromocytomas. That might help your diagnostic abilities as well, right? So here is this lady actually has a bladder pheochromocytoma, and you can see over here that is what she had. And this is an MIBG scan. Now this MIBG scan, normally the isotope will go and settle in the bladder. So if you do it after 1 or 2 days, you might get this in anybody. But we generally ask them to void, and maybe after 3 days or maybe even longer. And we have it still collects there, and it means yes, that's consistent with the diagnosis. Nowadays, our imaging is so good, we don't do these. We just, the MRI will give you fantastic imaging to identify this. And our urologists have also done a great job with these tumors as well. They actually they are usually in the around the bladder rather than inside the bladder in most situations as well. You know, the sympathetic chain, that's where they actually arise from as well. But she did really well. She had a partial cystectomy. She has normal bladder function, and she's subsequently doing extremely well. Biopsy, extrarenal paragangliomas, urinary metanephrines, and this is a stain, a chromogranin stain, which is positive in this patient. That's a series as well. Okay. And this cluster, third cluster, is actually the, well, at the moment thought to be uncommon as well. These are tumors which are largely located in the adrenal glands, and they tend to be a lot more aggressive in their due course. By and large, surgery is the treatment of choice as well. So aggressive type, you know what Ki67 is? What is the other name for Ki67? You guys have pathology meetings and all that? You meet pathologists? No. Do you do biopsies anymore in medicine, or you kind of have intuitive clinical thinking where you don't need to do any more biopsies? Right. Ki67, what is the other name? MIB index, right? Okay. So anyway, the proliferative index of the tumor is what you're looking for there. High chromogranin expression in these tumors. And so 28-year-old lady, history of some pain, swelling in the joints as well, had high-grade fever, lost a lot of weight. And this is what she looks like. And of course, I'm sure you would have done an appropriate rheumatological workup in this lady. What would you do? SLE, rheumatoid arthritis, that's what you would have thought about. And all that was negative. And on her fever workup, we picked up a lesion, a large lesion in the liver. Primarily, catecholamines are negative. This fits your cluster 3 diagnosis. Liver biopsy showed neuroendocrine tumor as well, and chromogranin staining is positive. And this is the MIBG scan, which you can see over here. And this is a paraneoplastic syndrome presenting in this cluster 3 tumor. So we gave her steroids with the tumors, the arthritis resolved. SSTR, we use the octreotide over here, the somatostatin receptor analogs. And so here is a pre-treatment scan after giving MIBG therapy. It's much better. So we had, I think, a 3 to 4 year follow-up on this lady, and she was okay at that point of time. Okay, so that's basically the summary about Pheos and paragangiomas, and I'll go on to my next bit. Can I take another 15 minutes? Is that all right? Okay. Right. Any questions before I go on to the next bit? Wow, this telepathy thing, artificial intelligence really beats me. Okay, right. Right. 32-year-old lady from Bangladesh, recurrent episodes of flaccid quadriparesis, hypertensive for 3 years, on antihypertensives, and that's what she's on. Grade 3 hypertensive changes, A2 loud, has muscle weakness. So when you have someone who comes with flaccid quadriparesis, what do you think about in medicine and casualty? First thing you think about is fantastic, GBS. Then you think about other things like this. So what's the first diagnosis you think about with someone who comes with a low potassium? Huh? Yeah, that's true. But so what cause? What do you think about first? Number 1 on the list? Renal tubulastosis. If they're not hypertensive, you think about renal tubulastosis. That's the first thing that you think about, even without seeing the biochemistry. You see the potassium, you forgot about the bicarbonate and the chloride, but they are acidotic. So bicarbonate low, chloride high. That's it, right? But over here, this kind of presentation. Now, the important thing is in hyperaldosteronism, which is obviously what I'm talking about here. When you recover from RT, renal tubulastosis, in between, very often the muscle weakness will actually normalize. Over here, the persistent muscle weakness in most situations. So sodium is borderline high. You don't always see that. Why don't you always see this? Why can't the sodium be normal? What's the reason why the sodium is normal? I can still tell you. Page 150 in Ganong in the year 1982. It mentions there one line. We didn't even know what hormone causes it. What's it called? Huh? Have you heard of a movie called The Great Escape? Right? Okay, this is not The Great Escape. It's called the aldosterone escape. Right? So you have an escape from aldosterone. Why do you have an aldosterone escape? Why isn't so you have an excessive amount of aldosterone here. The sodium doesn't go up. What's the reason for that? Because another hormone is produced, which we didn't know in the 1980s. Atrial natriuretic peptide. So because that is produced, the sodium generally does not go high. So they have hypokalemia. Sodium is usually in the normal range very often. And so typical features over here. And here is a CT scan showing a low Hounsfield density lesion. Now, typical aldosteronomas are usually smaller, less than 2 centimeters, 3. They don't usually become big. Once it starts causing 4 to 4.5, we think about nastier things than that, adrenocortical carcinomas also. So this could be a case. Nowadays, we also measure one more hormone in addition to the renin and aldosterone. Do you know what that is? When you have periodic paralysis, we also check cortisol, because a proportion of these patients, about 10 to 15%, may have what is called Cushing syndrome. Heard of Cushing syndrome? Cushing plus conching. I haven't invented the word, by the way. Okay. Con syndrome. The tumor produces both cortisol as well as aldosterone. Right. So this is a term which has been coined about 7 or 8 years ago, and it's now very much part of our physiological. So we shouldn't presume that it's only producing aldosterone. Could be producing. Vice versa may be true also. Mild Cushingite features, but also producing aldosterone. So that is possible. Treatment of choice, once you identify the lesion, is obviously remove it. The opposite adrenal will be normal in size. It won't be out. And here you can see the opposite adrenal, which is normal in size, and there is no atrophy. Unlike when you produce. So if this was producing cortisol in addition, the opposite side will be atrophied. So in a conchings, the opposite side will be atrophied as well. So when you check aldosterone and renin, the main precaution is the patient shouldn't be on spironolactone, epinephrine, whatever. Should not be because what? Because it produces a chemical called candrenone, which takes about 3 weeks to wash out. So ideally speaking, we should be measuring that. Okay, potassium candronate. So you don't generally, you shouldn't be doing it ideally. But then we have these patients on big doses. Spironolactone had lots of periodic paralysis come here from Timbuktu, and in those patients, we wouldn't like to stop the spironolactone. There are practical logistic issues sometimes as well. Right? So 50% of cases periodic paralysis. That is what has been reported in the literature. And there's a lovely old publication way back in 1989 by Sheshadri, wherein we didn't have aldosterone and renin in the 1980s, just measuring urine potassium levels and doing an imaging of the abdomen, which is very often ultrasound. CTs came in much later on, and being operated and doing extremely well after surgery. So it's okay. So this is a typical aldosteronoma. These tumors, unlike the Pheos, which are very vascular, may look more beefy than this and dark because of the chromaffin deposits. They look down, dark brown, right? These look yellow over here because of the, what do they contain? A lot of, pardon? Lipid, fat. They have a lot of fat here, and so they are lipid containing lesions and the water clear cells of a typical aldosteronoma that you're seeing over here as well. Now, this is a really fantastic article by the man himself, Kohn, right? C-O-N-N. Jerome Kohn published this in 1964, and he described, you read this article, you should read it because it tells you about vision. People who just think about physiology and then start formulating thoughts that way. In 1964, he said that there would be, long before clinical potassium deficiency, you can have hyper. So there is something called normokalemic hyperaldosteronism, and it's not rare. So if you have refractory hypertension in your OPD, all right, and your renal artery Doppler is normal, and your cortisol is normal, you should check renin and aldosterone. I mean, okay, check the renin and aldosterone before you check the cortisol, because it may be iatrogenic Cushing's or something else. But check your renin and aldosterone in people who are on full dose of 3 antihypertensives. May not be that young either. They could be in their 50s. I had a recent 60-year-old man who had it. Rule it out. The CT scan may be normal. They may have what is called idiopathic hyperaldosteronism. So the zona glomerulosa is producing aldosterone. Should be thought about. He thought about it in 1964. They hardly had assays to measure these things at that time. So you can have potassiums which could be borderline normal or even absolutely normal, more than 4. Large proportion of patients with essential hypertension have primary hypertension. So that 5 to 6%, we will be seeing them in CMC. They are there. Look around for them. Okay. Incidental cortical adenomas with hypertension physically appear the same. He even thought about incidental omas before the era of ultrasounds. And he probably picked them up on postmortem studies, but he thought about this as well. That could be the case. So 5 to 13% of cases of hypertension makes up about 0.6% of adrenal incidental. And this must be something from the Mayo Clinic now when you're talking about 13%, but perhaps even CMC fellow. 3% of hypertension in primary care settings as well. That means outside the portals of this institution. 39% of patients with resistant, that's an endocrine bias, must be in an endocrine center, 39% as well. but these are the Endocrine Society practice guidelines of the United States of America, the greatest democratic republic in the world. Right? So, I'm sorry, India comes first. So, with the aldosterone-renin ratio being used as screening tool, prevalence of primary aldosteronism is average 6% in hypertension, and it's easy to do. Okay. All right. And maybe I should talk about when you have CT scans of the abdomen. Very often with aldosterone producing tumors, you may have nodularity on one side, and the opposite side also looks a little nodular. And you certainly, just because one side looks a little bigger, you don't want to operate on the wrong side. So these are isotope scans which can be done. We don't do this here because you need to have the betatron sitting out here to have freshly generated isotope. So, but here you can see the lesions may be bilateral, ambiguous, may even look multiple nodules in the same adrenal, and you can see one part taking up the isotope and the other one. And you must have heard about adrenal venous sampling. Yeah. It's an I'll just give a long and short of it. It's number one, a laborious test to do. And number two, you'll have to stop the spironolactone and whatnot, which is of course going to be a huge challenge. And you get ambiguous results even with that very expeditious test. So this is going to be replacing. So just to let you know, there's a spectrum over here. So that's why it's not like simple adenomas. There could be multiple nodules over here. And this is taken from JCM 2021. You can read that up as well. I'm just giving you a primer, but they can be multinodular lesions, bilateral lesions, unilateral lesions when it comes to the CT scan as well. And histopathologically also can be different. Young people with hypertension, and these are autosomal dominant disorders, we should think of this as a condition. Young, non-obese people, well, it doesn't mean that obese people can't get familial syndromes and that everyone has essential hypertension. The other way is true. It's like it's interesting, monogenic beta cell diabetes, MODY, which we do a lot of work with. We say non-obese young familial disease. The surprising thing is when we looked at our data, the median BMI was 24.5, which is by no means lean. So, and a good number of them, some forms actually had BMIs more than 26. So, young person with hypertension who's not, having a BMI more than 30 at least, please think of these conditions which might be there. Age of onset, generally less than 30 years, strong family history of hypertension, resistant hypertension, maybe resistant, may not be. Autosomal dominant, and the penetrance can be variable. So you may not have the typical autosomal dominant penetrance. Hypokalemic alkalosis may not be there. There may be resistant hypertension without hypokalemic alkalosis. And strokes in certain forms, which are young, and this form, dexamethasone responsive hypertension, very interesting form. Give them dexa, blood pressure normalizes. So, and mineralocorticoid agonists in familial hyperaldosteronism type 2, type 3, and type 4. So that's it. 30-year-old, 18 weeks of gestation, dizziness, left loin pain, severe hypertension, no Cushingoid features, bilateral edema, abdominal bilaterally left loin mass, fetal heart normal, grade 2 hypertensive changes, no virilization. Diagnosis? Anybody? Anyone? Palpable mass. Is it a Conn syndrome? No. Could it be a Pheo? Maybe. Could be something else? Who knows? Maybe. Right. Potassiums are low, which can happen even in Cushing syndrome, by the way. So dexamethasone suppression, 14 micrograms. Remember, dexamethasone suppression in pregnancy is not a great test. But the ultrasound showed a very big tumor there. When you see 12 centimeters and hypertension, you think adrenocortical carcinoma, not adenoma. That's it. This is a while ago. So that's why this is a kind of first generation kind of CT that you're leaving. It's a big lesion, and unfortunately, yeah. So this is our differential diagnosis as well, but the contrast did not take up. She had a spontaneous miscarriage, and after that, the dexamethasone suppression was not suppressing over here. So she was operated, and this is very different from what I've shown you in terms of Pheo. Can you remember the Zellenbollen? Not the water clear, but a very heterogeneous appearance, and this is an adrenocortical carcinoma that I'm showing you over here. Lot of mitotic figures, etc. How do you treat these patients? Adrenocortical carcinomas have a poor prognosis. Nowadays, pathologists will give you a proper staging, and you need to be very aggressive in treating these patients. All right. Mitotane is the drug of choice, but it costs a lot of money. And ideally, when you give it, it's very toxic. The doses we give for Cushing, sometimes we give it, are very low, 0.5, 1 gram. But when you give it here, you give big doses, 2, 3 grams, extremely nauseating medication to take, and you need to measure the mitotane levels to see how it's working. But this patient actually did well. After the tumor was excised, did extremely well. Okay. Now, I think we're running out of time. So I think I'll wind up. I won't talk about Cushing's. Right. So I'll give you a few questions here. Okay. Those of you who are sleeping can wake up. Good morning, uncle. How are you doing? Right. So what's your likely diagnosis? This patient. Sorry? Pardon? Cushing's, correct. But what kind of Cushing's? ACTH. Why are you saying ACTH? Because of pigmentation. Right. All right. So anything else? Could it be any of these? Iatrogenic, Cons, pituitary, pancreatic neuroendocrine tumor. You think it's, what do you think it is? Which one? At least 3 of them are ACTH dependent. Pituitary microadenoma, neuroendocrine tumor. Is this ACTH dependent? No. Is this ACTH dependent? No. He thinks there's a catch in this, but there's nothing. It's not ACTH dependent. These two are ACTH dependent. So which one would you prefer? The common thing, the pituitary microadenoma, young lady, right? She's young. I didn't give you her age, but she's around 30 something, maybe. All right. 35-year-old presented with hypertension, progressive weight loss, 3 months, blood pressure high, normepinephrine's high, urinary metanephrine 195, right? And then she also has this in her bone as well. So what's your diagnosis? Now, with your vast experience in the last 1 hour, can you pinpoint the diagnosis? Yes? I can guarantee I shall not be your examiner at the end of 3 years. And you can say whatever you want to me. Right? What's your diagnosis? Okay, let's go back. Start with the basics. There's a lesion there. It's vascular. Does it look like it's in the adrenal gland? No, it's very centrally located. And with the high normepinephrin, this is probably a paraganglioma. And you've got something here in the bone. What is it likely to be? Mets. So metastasis, paraganglioma, aggressive tumor is SDHB mutation, right? Remember the Beatles song? Let it be. Let it be. Right. I think I'm a little old-fashioned. Maybe we should go in for something else. Right. So this is an isotope scan of the same patient showing multiple lesions over there. The isotope, the MIBG all over the place, and also carotid body tumors, SDHB mutation in this patient as well. And that's what the patient had in terms of treatment. Well, lasted for about 4 or 5 years, but this is an aggressive disease thereafter. But even that, remember, 5 years of life with that amount of metastasis, typical of a neuroendocrine tumor, did pretty well. Your most likely diagnosis is STHB mutation. 40-year-old with hypertension, cortisol normal, aldosterone elevated, renin suppressed, sodium 144, potassium 2.6, normal renal function, hypokalemic, alkalosis, right? Just by the by, suppose you have a patient who comes to you with potassium of 1.5 to casualty, chloride is 110, and bicarbonate is 22. What do you think of? You don't answer. What should you think of? Not this patient. What do you think of? Anybody, anything. Anything goes. Sorry? So remember, when you have hypokalemia, what happens to the bicarbonate? Hypokalemia begets alkalosis. So even if you have renal tubular acidosis, with severe hypokalemia, the bicarbonate may not be as low as you expect. You have to correct it. And you know, there's a formula to do that as well. All right, go back and look. So, but anyway, you know by instinct that it'll actually may not be as low as expected. So that is renal tubular acidosis. Anyway, coming back to this patient, aldosterone elevated, renin suppressed. What do you see? What's the lesion? That is a adrenal adenoma. Is that it? This is a patient with Conn syndrome. Are you happy? What is the medication of choice? Aldactone is spironolactone. If in case you didn't know, the generic is spironolactone. Epinephrine, finerenone, amlodipine, telmisartan. Which medication would you like to use? The medication of choice is spironolactone. It is the most powerful medication. You won't go and treat cardiac failure, please use epinephrine. You don't need to. But if you want to treat Conn syndrome or hyperaldosteronism, you give spironolactone. Now, if it's a male and he starts developing gynecomastia, then of course you can change over to epinephrine. What about finerenone? It's the latest. The latest is always the best? No, not necessarily. So what it does is, finerenone is actually meant for patients who have renal failure. You're not going to use it here. And you may not even correct the hypokalemia. It is not the medication of choice for Conn syndrome. It has a totally different use. Similarly, epinephrine is second best. What about amlodipine? It's actually not a bad medication. It can in fact lower aldosterone levels to some extent. Interesting. Go and look up the mechanism. Right? Nothing prevents you from using telmisartan, but it's not the drug of choice. So sometimes you don't control the hypertension, you add on amlodipine and ACE and ARB as well. Now, those of you who are awake, what is the other anomaly on that CT scan? What? Bilateral adrenals. How many of you have done your MBBS and CMC fellow? Raise your hands. Okay, I showed this to you in your first year of physiology. The same CT scan, and you're looking at it now 15 years later. How many years later? Sorry. Huh? 10, right. Okay, sure. You're not that old, right? Okay, good. 12 years later, right. So, do you know what it showed? Huh? It says situs inversus, but actually it's a CT scan which has been flipped up wrongly by me when I put it on the slide. That's all. Okay, that's the correct. So you could probably say situs inversus as well, but it's not situs inversus. Right? It's actually just a mucked up CT scan on a slide. I put it the wrong way around. So you can see the liver on the left hand side and the spleen on the right hand side as well. Right. So that was supposed to be the MCQ. But the correct answer is actually none of the above. But with empathy, I can give you answer B if you want to. Okay, so all of you get back to the basics. Take a lovely history when you see a patient. For young onset hypertension, because of our propensity for metabolic syndrome, insulin resistance, we prefer to put the cutoff as less than 30, but then there's always gray zones. And remember that secondary hypertension can occur in older people. Hyperaldosteronism, older people. The mean age of our Pheos also is somewhere in their 30s, actually, not in their 20s. So all these things can occur in older people. This is your checklist. Resistant hypertension, severe complications of disease, do a proper workup. Patient comes to you with cardiac failure and a blood pressure of 110, 190 by 110, and the patient is on 4 medications with cardiac failure. He's in the ICU. What are the tests that you'll do? You'll do aldosterone and renin. He's not on spironolactone yet. Cardiologists have not put him on spironolactone. Oh, you haven't put him on spironolactone. So you can do it. That's not a problem. Can you do catecholamines? Think of the scenario. Guy in ICU comes into with cardiac failure. The catecholamines will be through the roof. You may get some 5,000 of normepinephrine's in this patient. So don't do it at that time. So contextually be careful at what investigation that you do. So look for all your features, subtle ones. Please palpate the neck for a thyroid gland as well, in addition. And simple things first. Adult polycystic kidney. Your basic investigations and your more advanced things when required to be done. Okay, thank you. Lots of people I need to give credits over the years. My whole department of endocrinology. I mean, many more people, obviously. And surgical endocrinology, nuclear medicine, molecular path, radiology, pathology, biochemistry, and all the endocrine staff, junior staff as well. Yeah. Okay, I think I've overshot my time. So thank you for your patient listening. Any questions? Maybe you should lead them into asking questions.
Sir, is there just one question, sir?
Yeah.
Is there a role for saline infusion test in?
Yeah, there is a role when you have ambiguous diagnosis. You have to be very careful when you do it, because when you're infusing saline, you might raise the blood pressure. But we occasionally do it. We don't do it very often, but we do it occasionally.
Any other questions?
I think as and when you see a patient and you're working them up, I think the best thing is to just pick up the phone and call us, and we'll be very happy to help you out and doing the preliminary workup of all these patients. That's not an issue. But I'm sure my colleagues will be very happy to help you out, or you can call me directly also if required, right? Okay. Thank you so much.
Thank you. Thank you very much, sir. It was a very informative session, even for myself. I have learned a lot of new information from sir's lecture, and I hope it's the same with all the other registrars as well as the consultants as well. Once again, thank you very much, sir, for having come today, and we'll break for lunch.